Plug the FLAG project. It's families learning about GIST. They have a poster at the end of our row of posters. It's a genetic survey, basically. Anybody who's been diagnosed with GIST who's over 18 years is eligible to join. And the goal of Project FLAG is to learn more if other cancers or certain conditions are associated with GIST, perhaps diagnosed at a greater frequency than normal, not only with the GIST patient, but members of his family. It only takes a few minutes to participate in Project FLAG. You fill out a brief questionnaire that will ask about your history and your family's history. You might be contacted with a genetics counselor. You might be asked to provide a saliva sample from which they can test DNA. I never got past the questionnaire level. It only took me less than 10 minutes to participate in FLAG, but they're trying to get about 800 GIST patients registered. So in 10 minutes of your time and you can help out. MD Anderson is among the various institutions that are involved in Project FLAG. Pick up their forms. You can find them at the end of the poster row. Well, I'm delighted to introduce our next speaker, Dr. Soo-Young Kim, who's going to speak to us about the clinical and research advancements going on in the field of wild type and pediatric GIST. Dr. Kim is an assistant clinical investigator at the National Institutes of Health in the Pediatric Oncology branch. He is the coordinator for the consortium at the NIH that is studying pediatric and wild-type GIST. The consortium includes researchers from the NIH and several leading academic cancer institutions. The goal of the consortium is to discuss and learn areas that might further the advancement of the knowledge of pediatric and wild-type GIST. They also hold a clinic for patients diagnosed with these subtypes of GIST that meet twice yearly. Please join me for welcoming Dr. Kim.
Thank you very much for that warm introduction. I'd also like to thank MD Anderson and especially GIST Support International for giving me the opportunity to present some of the research that we've done in pediatric and wild-type GIST. It's a pleasure and an honor to be here. So the goal of our clinic was to define new targets for potential treatment. Also, we wanted to design innovative national treatment protocols. And so I'm going to use the following analogy to help describe the model that we chose for our clinic. So if you look at this flower, can anyone tell me what's wrong with this flower? Yeah, I can't quite hear it, but actually I want silence because I want to say there are no botanists in the crowd. And also, if someone does know the answer, it actually ruins the analogy completely. So, but if I actually show it in, sorry, now I'm having problems with this pointer. Now if I show it in this context, then it's a lot more obvious, right? Then you have the flower with the purple on the inside compared to all the other flowers that have red on the outside. And so if you actually collect these purple flowers, then you can see that there are variations in all of these. So the one next to it actually has a little yellow on the center. The one next to it has purple on the outside. The one on the bottom, again, has the same yellow coloring. And the one on the inside has these purple sprouts coming out. And the questions we wanted to answer were, is the flower purple because some of the changes around it, or are some of the changes that you see around there a consequence of the flower being purple, or are they just completely independent events? One has nothing to do with the other. And so that is exactly what we did. And so our objective was to assess every child and young adult in the United States with GIST, and we wanted to bring them to the NIH, and we also wanted to have clinicians and researchers who are experts in the field of GIST to meet them also. We wanted to obtain clinical parameters and samples for research testing, and we definitely wanted to continue long-term follow-up. So that's exactly what we did. We had a handful of specialists, pediatric oncologists, pediatric surgeons, some of the leaders in the field come together. We had the fortune of having Konstantin Stratakis already at the NIH. He has a bunch of named diseases after him, including Carney-Stratakis syndrome. And we also had the support and continue to have the support of two great patient advocacy groups, GSI and LifeRAF Group, who've been with us there from the beginning. And we brought patients to the NIH and their families for this first clinic. And truthfully, it was kind of stacked in our, we thought it was kind of stacked in our favor. No, I'm sorry, is there another, can I just say next slide? Yeah, thank you, it doesn't seem to be working. We thought it was going to be stacked in our favor because about a year prior to the clinic, the timing was perfect. We had had these research findings, and this is findings provided by Katie Janeway at Boston Children's. And on the very left-hand side, you see what's called a Western blot. That just shows how much of a certain protein that the tumor has. And you can see all of these dark bands. And I'm sorry, is there any way you can show me how to actually do the... Oh, I see, much easier. Perfect. So now you can see that for pediatric wild-type GIST patients, they have a high level of this protein called IGF-IR, insulin-like growth factor receptor type 1. And compared to normal controls and also adults with KIT-mutated GIST and pediatric patients with KIT-mutated GIST, you see that there's a lot more of this IGF-IR in the tumor sample. Concurrently to that, we were also part of a national study studying IGF-IR in the treatment of patients with another very rare pediatric tumor called Ewing sarcoma. This is a bone tumor. Patients are refractory to chemotherapy, radiotherapy, surgery, very aggressive in the recurrent setting. And we had a few percentage of patients, I believe about 10%, who were treated with IGF-IR antibody and had their huge tumors actually shrink down to nothing. So we thought the timing was perfect. Here we have another patient population, patients with wild-type GIST who have high IGF-IR in their tumors, when we thought it'd be perfect candidates for the antibody trial. Unfortunately, so several pharmaceutical companies have terminated their IGF-IR antibody projects. It's frustrating to me, and I'm just not going to go into it any further, otherwise I'll start harping for the next half hour about why this is a travesty. But we're still currently pursuing other options, and this includes using small molecule inhibitors to actually target IGF-IR. There are also many centers that offer phase 1 and phase 2 IGF-IR antibody trials, not specifically for patients with GIST, but for patients with advanced cancers. And so if you have wild-type GIST, and if your doctor believes that you would benefit from this, there are centers that still are open that you can get treatment. So another thing that we found is the role of surgery for recurrence. So we had the pleasure of having Dr. Michael LaQuaglia, who's widely considered one of the leading pediatric surgeons in the United States. And he hinted to us from the very beginning that he and his colleagues have seen patients who come back after multiple resections, 1, 2, 3, 4, 5, 6, and they keep coming back for these surgeries. And he told us that you can always get the tumor out, but after a certain amount of times, you actually do a lot more harm than good by going into the stomach to do a surgery. And so when a medical oncologist tells you that, you kind of maybe don't pay that much attention. When your surgeon tells you that, you actually listen to it a lot more carefully. And so this is some of the results that we got from all of our clinics. We've had 5 clinics so far, and 58 patients have attended. And so what you can see is that of those, 46 underwent resection following diagnosis, and 34 of those have recurred, which is 74%. There is still a group, 12 patients, who remain in first remission, and they actually have follow-up anywhere from 19 to 67 months. We continue to hope that this represents a benign form of GIST where surgery is curative. We just need more patients and more follow-up time to determine if that's true. But here you see some example of what Dr. LaQuaglia was talking about. So 18 patients have undergone a second surgery, and of those, 14 have recurred, over 78% of our patients. In addition, 4 also underwent complete gastrectomy, and even in that setting where you take away the entire stomach, people have still recurred, again, 75%. And from that, we concluded that surgery in itself is not curative in the vast majority of cases of recurrence in the setting of wild-type GIST. And we have been imploring our patients to avoid radical surgery. This includes resection of the entire stomach, a complete gastrectomy, and also resection of the small bowel. If you take out enough of it, you're going to lead to something called short gut syndrome. This is more important in the pediatric situation because kids are growing and you do require nutrition for continued growth. There are reasons to undergo surgery, though, if the lesion is causing any symptoms, and this includes pain, obstruction, ulceration or hemorrhage, impingement upon any vital organs, or if you have multiple lesions and only one is getting bigger while the others are remaining stable, then we believe all those are good reasons to undergo limited surgery, but again, avoiding radical surgery. So for our second clinic, we invited some of the leading medical oncologists in the field to come to our clinic, including Dr. Suzanne George at Dana-Farber, Dr. Margaret Von Meeren at Fox Chase, and of course, Dr. Jonathan Trent here at MD Anderson. The reason we did this was we wanted to invite more adult patients with wild-type GIST, and we wanted to ask the question, do adults with wild-type GIST behave more like the kids or to their counterparts, adults with KIT-mutated GIST? I can say without a doubt, 100%, that the adults that we invited acted more like children than the children and the adolescents who actually act very mature in our clinic. And that's, I'm a pediatric oncologist, so both of those are really good things. But unfortunately, we don't have, our thinking is that older patients with wild-type GIST tend to have more recurrences and tend to have a little bit more aggressive disease than the kids. Right now, we do realize it's a very selected field. If you're doing well with GIST in your 60s, haven't had a problem for 20 years, you're never going to come to our clinic. On the other hand, kids, the patients are going to force them to come. Kids don't really volunteer and say, I'll go to the clinic. The parents actually bring them. And so we do have a very definite referral bias. We just need to do large global studies to see if this actually does hold out. We could make some conclusions on what to do with tyrosine kinase inhibitors. So again, 58 patients have attended our clinics. 81 patients have tried tyrosine kinase inhibitors, and obviously the number is larger than 58 because people have been on multiple inhibitors. And so this slide shows, again, people who have had complete response, partial response, disease stability, progressive disease, or those who stopped due to side effects. And we do have a list of all the common ones that people have taken. What is disappointing about this slide is that there are very few people on this side. We've had only one patient who's had a complete response with sunitinib. 2 others had a great initial response while on imatinib, but unfortunately they did progress. It was actually my thinking that they weren't truly wild-type patients, and so we actually asked the pathologist to look at the recurrent sample to determine if they did have KIT PDGFR mutations, but it turns out that they were both wild-type. And the numbers are really small, 1%, 0% here. And if I can just have a show of hands of people in this room who've had good responses to Gleevec. Right, so a lot more than 1 or 2%. What is actually encouraging, though, is that people are having stability of disease on some of the newer ones. So especially high-dose imatinib, anywhere from 600 to 800 milligrams. 6 of our patients have had stable disease and have had it for a long course of time, over 2 years. In contradistinction of that, those who've had progressive disease have actually progressed relatively early in their course, about 3 to 6 months after starting. Nilotinib is also one of the newer third-generation types of tyrosine kinase inhibitors. People have only recently started on this in our clinic, and so the stable disease population, we just need to get longer follow-up to see how long they've had stability of disease while on nilotinib. So the conclusion from that was that the response rate to tyrosine kinase inhibitor therapy is much lower than for adults with KIT PDGFR mutated GIST. And so we've been advising patients to take TKIs in the neoadjuvant setting. And by that, what I mean is that if you have a recurrence, we tell people not to go to surgery right away. We'd like you to start a tyrosine kinase inhibitor and assess for response. If the tumor keeps growing while you're on that, then you just stop and go on to the next tyrosine kinase inhibitor. If you have stability of disease, you stay on that. And we are hoping that with the newer generations of people will start having disease shrinkage. So having said that, you might get the impression that kids are doing very, very poorly because we're telling them no surgery. The response to tyrosine kinase inhibitors have been very, very low. But despite these findings, what we found is that the vast majority of our patients, over 85%, are doing very well. And that kind of shows that there is a difference between adult KIT-mutated GIST and pediatric wild-type GIST. We do have a poster up where we do go into a lot of these findings in more details if you're interested. So in our third clinic, we actually had a hint of this from the first clinic, but now we had more numbers to actually analyze it. We started studying succinate dehydrogenase mutations. So succinate dehydrogenase, or SDH, is a component of something called the Krebs cycle in the body, in the cells, and it's involved in cellular energy. Best analogy I can give, it's kind of like a gas tank in your car. You got a car, you got a lot of important parts. You don't put any gas in it, it's not going to go anywhere. So this is what supplies the fuel to the cells. We knew from earlier work from Dr. Carney and also Dr. Stratakis that there are patients who have a dyad of disease, namely gastrointestinal stromal tumor, in addition to another tumor, an endocrine tumor called a paraganglioma. And when they've looked at these patients, a lot of them had mutations, germline mutations in every cell of your body in this SDH gene. And so what we did was for patients who came to our clinic, we actually assessed SDH germline mutations. And it actually did surprise me that we expected one or two. So we expected one or two patients to have Carney-Stratakis syndrome, and we expected they would have SDH mutations. However, when we looked, the vast majority of our patients had isolated GIST. And even in that case, we did have a large preponderance of SDH germline mutations, about 15%, depending on how you look, because we don't have the results of the fifth clinic yet. These were in a few forms, so there are a few subunits to SDH, A, B, C, and D. We had 2 patients who had mutations in SDHD. We're still trying to work out whether it's something called a polymorphism, where it's a change but it doesn't affect function, or whether, like the others, the Bs and Cs, whether they're true mutations, which means there's a change and it leads to what we believe is loss of function in this case. We also looked at the clinical status of this patient, and we asked, if you have an SDH mutation, are you doing a lot better? Are you doing a lot worse? And it actually spanned the board. We did have one patient, unfortunately, who succumbed to disease just last year, very young patient who fought for about 4 years. And then we have other patients who have no evidence of disease following their first surgical resection, no therapy at all, just surgery, and the longest person is about 67 months out, so over 5 years from original diagnosis, again, with no signs of tumor. And in between, there are all sorts of other patients, those in first remission, second remission, those in first recurrence, second recurrence, but it seems like the majority of our patients, they all have stability of disease. So this is another Western blot that we show. So this is work that Katie Janeway at Boston had actually started on her own, and then when she learned of the germline SDH mutations in our clinic, she took it a step further. So she had her own cases of wild-type GIST, and to that she added our case of the wild-type GIST, and she asked the question, what are the levels, the protein levels of SDHB in the tumor? And again, it was something very surprising that we didn't expect. When you look at wild-type patients, regardless of whether they have a germline SDH mutation or not, what we found was a complete lack of SDHB expression. And so we have gone back to some of these tumors that we do have access to, and it seems like those people who have a germline mutation, you actually lose the other copy of the gene, so now you have no functioning SDHB, which may explain the findings that you have up there. So this is important to us because there are some treatment implications. So currently there is no therapy that targets SDH mutations available. However, if you look at this cartoon here, you can see that SDH is important in actually catalyzing the conversion of succinate to fumarate. Yeah, a lot of big words you really don't need to pay attention to. But in the end, what happens is that if you do have a buildup of succinate due to loss of SDH, you may get increase in in this gene called HIF-1 alpha, or hypoxia-inducible factor 1 alpha. And that in some cancers, they found that if you have high levels of HIF-1 alpha, that you may have more increased angiogenesis and more likelihood to metastases. So we have been, the patients who have come to our clinic have been undergoing HIF-1 alpha expression analysis, and the reasoning for that is that if they are high in HIF-1 alpha, then we do have indirect HIF-1 alpha inhibitors, and these include drugs like bevacizumab and a form of chemotherapy is topotecan. Again, not direct therapy, but these do tend to decrease your levels of HIF-1 alpha. So patients are undergoing evaluation for that. So the conclusions is that we have seen SDH mutations that are associated with GIST alone without anything else. GIST and paragangliomas, also known as Carney-Stratakis syndrome, and one patient, GIST and pulmonary hamartomas. This we think is a little different than the pure Carney's triad, which is GIST, paragangliomas, and pulmonary chondromas. Again, we just need more patients to see if it really does, if it is part of that triad or not. One thing that is very, very important about our findings is that patients with an SDH mutation are going to be at increased risk of paragangliomas. And so for the patients who we do identify mutations, we suggest getting an MRI of the neck yearly, and that's because a lot of the paragangliomas tend to grow in the neck region. We also suggest yearly monitoring of something called catecholamine and metanephrine levels. These are some enzymes that actually get secreted by the tumor, and so if they're high, then we can actually predict what's going to happen. And also extensive genetic counseling. This is germline, meaning that you probably got it. If you have a mutation, you probably got it from one of your parents, and also there's a 50% chance that you'll be passing it on to your children. And so we do not do any testing at the NIH without getting a full genetic workup first. And so people are aware of all of the implications of having a mutation. They get to decide whether they really want it or not. And we encourage people to talk to all their family members before getting the test. And then we'll be happy to run the test at the NIH at that point. So in our fourth clinic, we actually work with a very talented dermatologist, Dr. Heidi Kong, who is also at the NIH, and she focuses on, her expertise is on the dermatological manifestations, tyrosine kinase inhibitors, especially with sunitinib and the hand-foot syndrome that comes with it. So we sent a lot of our patients up to her because they requested a dermatological consult to help in those symptoms. And every time you get a consult note back, she always mentions these benign melanocytic nevi. So these are just these brown nodules up here, and really unconcerning. You can tell by the name, benign melanocytic nevi. If that's not clear for you, I can actually show you the ones that I have on my arm afterwards. But what is important is that we do know that there's something called BRAF. It's another signaling molecule. It's below, it's not on the cell surface like KIT, but it's below KIT inside of the cell. And it does sort of the same things. It acts to signal to the cell on when to turn on and off. We do know that BRAF mutations are high in benign melanocytic nevi. And we also knew before the clinic from Dr. Antonescu and also another paper published from a French group that GIST tumors did have BRAF mutations. So this is just a list of all of the positive BRAF mutations that they found so far. And so you can tell that it's evenly divided between male and females. This we were actually very struck about. This is the age that the patients were at the time of diagnosis. So very old patients. Sorry about that, I'm a pediatric oncologist. Anyone over 18 is old, okay? But, so you can tell like the youngest patient was 38 and the oldest was 78. They did look at some pediatric samples, but they just didn't have enough. What was more striking, and they didn't notice this right away because Christina's paper only had these two cases, and I believe that one. But if you look at the other result, it's a striking preponderance for small intestine involvement of the primary tumor. This is even more striking in our case because 85% of patients who come to our clinic only have stomach involvement as a primary site of involvement. So they try to look to see if there's a correlation of size, and what they found with their small tumors, very large tumors, and they tried to also correlate with mitoses, but they found very few mitoses in some and a very, very high number of mitoses in others. So we actually looked in our clinic samples. We had 33 samples that were amenable to analysis, and of those, 3 were positive for BRAF mutations, about 10%, and they were positive for this V600E mutation, which is kind of like KIT. If you have this mutation, it turns it on all the time. And so when we categorized about age, gender, and location, this is a little deceiving because this patient was actually 38 years old. So it's basically older patients and not seen in the pediatric population. This was again striking because most of our patients were females. There were no females who had BRAF positivity. As opposed to that, we only had 9 males in our clinic. And again, this is despite our attempts to get more males into the clinic and giving them priority over females, because we do know that there's this discordance between males and females. But so we had 9 patients, and we had 3 of those that were positive, which is a strikingly high rate of 33%. In addition, we also stratified by location. 0 patients out of 26 with primaries in the stomach had this mutation, whereas 3 out of 7 with other locations, mostly in the small intestine, were positive for BRAF, the activating mutation. We also correlated with clinical course, and again, this was similar to our SDH results, kind of varied. We had 1 patient who was in second remission, doing very well over 10 years out from the original diagnosis. We had another patient who was in his 3rd recurrence, 3 years out from diagnosis, and 1 that was just recently diagnosed, but had a huge amount of disease and was never resectable. So again, it just ranges from doing very well to not quite so well. So there are also treatment implications for this. There are a lot of patients with melanoma who have BRAF mutations, and they've had a very good response to treatment with this drug called PLX4708. Right now, I believe they're currently in a phase 3 trial trying to get this licensed and out in the market, so they're only treating patients with melanoma right now. There is this other tyrosine kinase inhibitor called regorafenib. Whenever George Dimitri emails me, this is the way he spells it, with the RAF in capitals, to probably highlight that point. And there's also another drug, AZD6044, which is a MEK inhibitor, and MEK is directly downstream of BRAF. So if you think that BRAF is activated, MEK should be activated also, and by inhibiting that, you should have a response in theory. So our conclusion is that BRAF testing should be a part of all mutational analysis. Patients who have V600E, that mutation, should be evaluated for clinical trials. And for anyone who has a pediatric or wild-type GIST, there are no genetic consequences to this because it's not a germline mutation. It's just something that occurs in your tumor, and there is treatment implications. So if you send your sample to the NIH somehow, we will test it for BRAF free of charge. So our 5th clinic was very exciting. The one person who didn't attend was Dr. Trent, and that's because he had a 25th wedding anniversary, so we thought that would be more important than this. But we actually invited 8 researchers throughout the world who are actively researching GIST, and we had each of them give a 15, 20-minute talk about what they were doing. No introduction, no background, just result, result, result. And it was very striking, and we learned a lot about all the great things that people are doing. We try to make these available, but they're so new and so preliminary that after it gets published and after we can confirm what they found, we will make these tapes available over the internet. So this is one project that we were actually performing at the NIH at this time. This is work done in Paul Melcher's lab, who's one of the great genomics people at the NIH. Something called comparative genomic hybridization. And so the best way to describe it is if you have 2 sets of normal cells, you label one green, one red, split them apart, and then mix them together. The green and the red should come together, and you should get yellow, because that's just the way it works. So the other thing we do is we take tumor cells, label them green. We take normal cells, label them red, break them apart, put them together. So the majority of the samples you're going to see are going to come back together properly, and they're going to be yellow. But you also see these portions where parts are green, meaning you have too much of that chromosomal region in your tumor, or green, where you have not enough of that chromosomal region in your tumor. So it's a global assessment of what your DNA looks like. So I'm just going to show you, this is an actual result of one of the slides. So I'm going to fast forward one slide to just give you an idea of what else it looks like. So that's your comparison. So going back to this one, this is all 23 chromosomes listed from 1, 2, 3, 22 autosomes, and then an X and a Y. And then if you're here at this level around 0, it just means that your green and your red came back together, and it's mostly yellow. Here, if you're up past that green line, then it means you have 2 copies. You have double the amount that you should have. This, you can tell, is actually a female because she has 2 copies of the X chromosome instead of males who have an X and a Y. So you expect to see this little blip, which is double the amount. And if you see anything down here, it means you have loss of some part of their chromosome. So this shows that you're basically normal, or there are no, normal is not a great term, it's copy neutral CGH. And what that means is you don't have gross abnormalities in your chromosomes that we can detect. So on the other hand, this is another actual patient sample. So here you can see chromosome 1, you have increased regions of some of that chromosome, decreases in others. Chromosome 3, you have a lot of loss of that. Chromosome 8 is over here, and again, you can see increases in chromosome 8. And here, again, it's a female, XY, because 87% of the patients in our clinic happen to be females. So we actually characterize what areas were lost. So there are several areas that we're interested in. 1P, again, that actually contains the SDHB locus, or SDHC locus. There's 9P. We have whole losses of chromosomes 13, 14, 15, and we have gains of a bunch of chromosomes. So the outcome of that study was that we had 22 patients that we incorporated in that study, 20 generated useful data. 30%, 6 out of 20, had no aberrations. Again, the first slide that I showed you, what we call copy-neutral CGH. And 14 out of 20 patients had this abnormal CGH pattern. Again, we also saw a spectrum of abnormalities observed. First question everyone asked me is that if you have copy-neutral, basically normal-looking CGH, does that actually affect how you do clinically? And that's the first thing I actually did look at when I got the results. Unfortunately, we just have only 6 patients, and they are very variable, but it seems like, and there's no scientific validation for this yet, but it seems like the people who have the copy neutral are doing better than the people who have the multiple changes. We just need a lot more samples to actually validate that. So the conclusions are we need to determine if a copy neutral CGH pattern correlates with any clinical parameter. And we're also collecting matched normal blood from patients with copy-neutral samples to begin something called transcriptome sequencing. I'll get back to that in a second. So the 6th clinic is actually scheduled for January 19th and 21st in 2011. These do occur twice every year, and we're on our 6th clinic right now. We do have 8 of 12 appointments scheduled. There is a wait list for adults with wild-type GIST. And the reason for this is that we are a pediatric clinic. We are going to give precedence to kids, to young adults, and then only after there are slots open are we going to take adult wild-type GIST patients. We do screen each patient who applies individually. If we think that by attending clinic they will have a clinical benefit, then of course they get precedence also. So we have reserved 4 slots right now, so if there are any children or young adults out there with GIST, we will give them preference and see them in our 6th clinic. In addition, after the talk on the 5th clinic, all the research talks, we actually, some of the stuff was just so amazing that we asked 3 people to participate in our clinic in terms of more research. So we did send samples to Dr. Annette Dunsing over at University of Pittsburgh, Dr. Maureen O'Sullivan at Trinity College in Dublin, and also Dr. Joshua Schiffman at the Huntsman Cancer Institute. And they're going to be performing research that we do not perform at the NIH and actually keep this field moving forward. So let me take you back a step. So by one aspect, you can say we've been very successful at what we've done at the NIH so far. We've taken a very rare subset of a rare disease, and we've done clinical studies, molecular studies, genetic studies to move the field forward. However, another way to look at it is what was our goal? Our goal was to find new targets for potential treatment and to design innovative national treatment protocols. So neither of those I've actually given you a result on yet. So we think we do have a ways to go. We do know that there are a lot of techniques that we can use to actually move this field forward. And then the question is, how do we actually get to this goal? And so the vision of the future that we have is a sequence-based detection of mutations that drive the formation of pediatric GIST. Let me just give you another analogy to give you a grasp of what we're actually doing and how hard it is for us to do. So there are 6 billion base pairs in each cell of your body. In the DNA, there are 6 billion base pairs. And a good comparison is the number of people in the world. So there are 6 million people in the world. So if I asked you, where is Jonathan Trent? I'll begin. Are you Jonathan Trent? No. Are you Jonathan Trent? Yeah. Yes, that's simple, right? So you may ask, it's that simple. And for people who have KIT-mutated GIST, it is that simple. If you come in with a GIST and you ask, do I have a KIT mutation? It really is that simple for me to tell you, yes or no, you have a mutation in KIT. So let me ask you another thing. Where is John Smith, who has a little mole right here? Right. How do you even go about asking, how do you even go about trying to answer that question? And just assume you don't even have access to the internet now. Just think about how much harder it is then. So that is what we're trying to do. We are trying to get the sequence of every single base pair to see if there is one mutation that is driving your GIST. So that's what we're up against. Difficult by all manners, but we think that we can actually simplify things a bit. First thing we need is samples. If we have something called a fresh frozen tumor sample, then this task becomes enormously simpler. So all we need is a little bit of tumor about this big. The problem is it needs to be frozen at the time of surgery. It's a preservative. It's like having a steak. If you put it in your freezer, you can take it out a month or a year later. It may not taste as good, but it's still edible. But if you take that same steak and you put some wax and preservative on there, you probably don't want to eat that a year from now. So we can do this, and we have been asking our patients whenever you go to surgery, and of course, if you've been paying attention to what I told people is don't go to surgery, so we're kind of hurting ourselves in this endeavor. But if you go to surgery, make sure it's fresh frozen, and make sure that you can get some to us, and we are very willing to do this whole genome sequencing for those samples. For the 8 copy neutral samples that we did have, what we're going to do is something called what we call a druggable genome screen. And so we have enough DNA from that sample where we can do limited sequencing of the genes that we think are important in GIST, or that we have drugs that we can target. And therefore, if we do find a mutation, then we can easily translate that into the clinic by giving them the drug that targets that. The problem that we're going to have is that most of the samples are going to be preserved. So at the time of surgery, almost no one goes in thinking they have a GIST. And so the surgeon goes in, usually at a small community hospital, and they're like, oh, wow, this looks like a GIST. And so there's no preparation ahead of time. But what is available are these small little blocks. So they're in preservative, and there's blocks about this big. What we're trying to do is take something like this, perform something called genome-wide amplification. So we're going to take the DNA from that little preserved block, amplify it so it fills up like this whole room. And then we believe using that as a sample that we can actually perform some of these genome sequencing studies. And so for the past 2 years, I've just been begging, pleading for people to send samples. They've been trying, but we found out that it's going to be limited. So we have to go with what we have. We have these paraffin-embedded blocks. We just need to improve our technology to make them useful for what we want to do in our studies. And again, it's going to be multiple collaborative efforts. It's not going to be just us. It's going to be researchers throughout the world. And we are willing to collaborate with anyone throughout the world who's working on pediatric or wild-type GIST. So this is a lot of people work on this. So these are people who actually play a pivotal role in all we do. It's not just seeing the oncologists. People see dermatologists, pain management specialists. They see dietitians, radiologists. Someone even asked for a Reiki expert, and we actually provided that. And again, it's a worldwide collaboration. These are clinical centers who participate in our clinic, some of the biggest centers and national leaders in the field. 2 research collaborations. We have the backing of 4 national institutes. And again, GIST Support International, LifeRaft Group have been there from the beginning and continue to provide amazing support. So our thanks to all of the physicians and researchers. They do volunteer their time, and they do volunteer their time very enthusiastically, which helps the clinic move forward. GIST Support International, again, they've been there from the beginning and continue to provide amazing help to us, but mostly to the patients and to their families who volunteer their time also to come to our clinics. Thank you very much.